Good afternoon, and welcome to the webinar. Thank you for joining us in Greensboro AHEC's Provider Training Webinar. A special shout out to THN providers who are joining us today. We will focus on setting up virtual visits, website manner, and tips for the exam. I'm Dr. John Jenkins. I'm a board-certified internist who helped to develop the digital health program at Cone Health. And now I'm an instructor in digital health and practice improvement with Greensboro AHEC, and a collaborator with the Department of Health and Human Services. Welcome, everyone. There are a few housekeeping items for us to address. The webinar is going to last approximately 45 minutes, and we'll have time at the end to address some questions. As Tina mentioned, to ask a question, because the microphones are muted by the host during the webinar, you'll need to submit that via the Zoom chat feature, which is in the control bar. Or you can text it to 336-707-3261. We'll try to answer all questions at the end of the webinar if we have time. And if not, I'll reach out to you individually with questions. Just for fun facts to know and tell, we are unable to address raised hands, so don't hit the raised hand button because we won't answer any of those things. And accreditation, this has been accredited for an hour of CME by the North Carolina Medical Society, by Greensboro AHEC. And full disclosures from me, I have no conflicts of interest to disclose. So let's move to the next slide and talk about the why. Why are we here today? Because we are now rebalancing our care model. Many of you had, during the height of the pandemic, had 70 to 90% of your patient encounters virtually. Now we're rebalancing our practices as we reopen them and assume personal care. The why for today is that patients have voted with their virtual visits, and they have now a preference, and many of them want to continue to be able to interact with you when it's appropriate virtually. And also we have continued COVID concerns around the way we register, bringing people in from their cars when the room's ready, cleaning our rooms. All of these concerns will affect, for some time, our ability to maintain high volumes in our face-to-face settings. Experts also believe that CMS and Medicaid are likely to continue parity with at least some of the visit types long-term. We know that we have 4 pillars to patient-centered care. We want to give the right access, and we want that access to be superior. The right care, the right time, the right place by the right level of provider. We want it to be reliable. We want the best care with the best outcomes, and we want it to be reproducible care. We want value-based care. And that's not only our cost to deliver care, but what costs do the patients incur when they travel, when they have to leave work, the gas in their car to get there, the wait time they have in our offices. All of these affect the value that a patient perceives. And finally, we want to understand customer loyalty, creating experiences that make them want to come back to us. Truly patient-centered care must have all 4 of these components. And as we move into the future, there's going to be a balance between virtual visits and our traditional in-person visits in our care models. And we have to plan for this together. So let's start with some important definitions. What is digital health? Well, digital health is the convergence of technologies with health and healthcare and living to enhance the effectiveness and efficiency of healthcare delivery, while making medicine more personalized and possibly even more precise by using big data, genomics, to really individualize for the individual and understand the needs of a wider community. It's a big, big umbrella term. Underneath that is telemedicine. It's really information exchange from one site to another via electronic communications. And the purpose of our telemedicine is to improve the patient's clinical health status. It allows health professionals of all types to evaluate, to treat patients in remote locations using telecommunication technology. And today that includes our telephone visits and our audio video visits and our asynchronous visits like MyChart visits. Telehealth is a subset of telemedicine. It describes specifically the use of audiovisual technology to provide real-time care, and often is referred to as a virtual visit or a synchronous visit. In literature, I often see the terms telemedicine and telehealth interchangeably used, but they're not, because CMS has a specific definition around telehealth, meaning that it is audiovisual. So when CMS uses the term telehealth, it really requires both audio and visual. If it uses telemedicine, it could be referring to both telephone visits and telehealth visits. Two important terms we have to clarify because they've changed because of the waiver. The originating site, which is the location of the patient. And prior to the waiver, the originating site was an office or a facility. Now the originating site can be the patient's home. And hopefully after the waiver, there'll be appropriate legislation which will allow the originating site to continue to be the patient's home. The distant site is the location of the provider, which was formerly also the office, but now it can be anywhere the provider is located, including their home. Digital health is often categorized by the way the technologies are used. And so 5 different ways to put them in buckets are mobile health, which is the applications on your smartphone, like Noom, which is a weight loss application, or a diabetic application, or a hypertensive application that gives you coaching and allows you to co-manage your health with the people who are managing the application, whether it's an actual live human being contacting you, or whether or not it is programmatic like an AI in the mobile health app. Remote patient monitoring is what we do when we're collecting data from the patient and then transmitting that data to the provider so the provider can make care plan decisions and adjust your medications or any care plan that you might have. This would be an example of diabetic, sending from a glucometer your blood glucoses, blood pressure cuff transmitting blood pressure data, weight transmitting weight data. Asynchronous telemedicine is most commonly used in our e-visits, where a patient selects a condition, fills out a questionnaire, submits it. The provider then reviews the questionnaire and then submits a care plan back to the patient. But asynchronous telemedicine is also used in offices that provide questionnaires via either the patient portal or through the email to the patient, and the patient completes the questionnaire, sends it back, transmits it back to the practice, and if the practice can actually have that auto-populate the chart, it creates an efficiency. If not, if a staff member has to put that into the chart, it creates more provider time to actually deal with the present illness rather than the clerical problems. So asynchronous telemedicine has opportunities to really look at creating efficiencies as well. AI is the ultimate way of creating efficiencies in our practice, and it's perhaps the fastest growing area of digital health. In many ways, it's used for decision support. So it puts data together and says, hey, this patient needs to be seen, or we need to contact this patient because their readings are off. Perhaps the remote patient monitoring or the mobile health tool is given data that allows the AI then to process that and contact you that you need to see the patient. It also can give decision support to the patient. In the United Kingdom, an AI called Babylon helps triage patients for the visits. And what happens is Babylon talks to the patient in normal speech. The patient then gives Babylon his information of what's going on. Babylon suggests, hey, you would be right for a virtual visit. I'm going to connect you with the provider. You need an appointment to see the provider. I'm going to make an appointment for you. You should go to one of our urgent cares immediately, and I'm going to call ahead or notify that you're on the way. And it's a great way of directing patient care. Cone Health is using a chatbot now on its website so that it can direct inquiries through the website to the proper locations. In South Carolina, Prisma Health is using AI for patient decision support in primary care. And these modalities can be merged together and should be merged together to create a seamless experience for our patients. If digital health is done properly, the technology should disappear. Today, we're going to focus on synchronous medicine. This requires the presence of both parties in the same time and communication link between them that allows real-time interaction to happen over an audio-visual channel. In healthcare, we have been trained in face-to-face in-person care. And all of us have our ways that we create that empathy, that rapport, that trust. When we walk into the exam room, we sit down, we create eye contact, we're level with the patient. We touch the patient on the shoulder or listen to them with our stethoscope, even if the visit's not for that related condition, to create that sense of trust and connection. How do we do that virtually? How do we create the empathy that we need in a virtual visit? We're going to focus a little bit on that. It involves expectation setting. It involves that making that connection, creating that trust, that rapport, which is really the way you use the medium. The way I like to think about it is thinking of yourself as a performer. So the performer has three parts. It has the venue, the provider setting. It has the audience, which is where the patient is. And we have stagehands that help us make the performance work. So in the provider setting, it's really important that you have a well-lit room. Minimal background distractions. If you look at the picture I've got there, it's very distracting if you're not a Clemson fan. And there's somebody peering over my shoulder, which is violating HIPAA and also causing a disconcerting sensation to the person who's trying to chat with me about what's going on. I never wear a jersey in the office, so it's kind of confusing to them why I'm this way, and they feel like they're getting less of a visit. A sound check. Hardwoods and tables can create echoes. Check the mic and speaker for feedback loops that are very annoying. And actually using a noise canceling device like a Jabra is better. I advise against using a headset because you convey to the patient that you look more like a telephone operator or a call center than a physician or provider trying to deliver care. The camera angle is critical, and we're going to practice this in a few minutes. If you look down at a patient, it really feels annoying. You want direct eye level contact, and that is created, the illusion of that's created by looking directly into the camera. Being centered on the screen is critical because if you're on one side or the other side of the screen, it's kind of annoying to the patient. And then creating that rapport. We talked a little bit about that just a few seconds ago. How do you create that rapport that the patient has an instant trust with you? Well, you look like a provider. So if you normally would wear scrubs in your office, and that's what people are used to seeing, wear scrubs in a video visit. If you normally wear a coat, wear your coat, a dress, or wear what you normally would wear to create that. If you have your stethoscope draped around your shoulders, do that, because then the patient sees something that's comforting to them, something that reminds them of the face-to-face office visit. Watch out for patterns and stripes. That can be very annoying in videos. And have a smile in your voice, energy in your voice, because you're communicating across a medium. For the audience, the patient setting. This is really important for pre-visit planning. So when you've given them the ticket, given them the appointment, or let them into the room, having a team member really help them set that stage for them. Good lighting, that's critical. You need to be able to see and observe the patient. Privacy, so tell them, hey, close the doors, don't let people in the room because they can hear what you're communicating to the doctor. Fixing the cell phone or camera in a fixed position with a good visual view of the patient, perhaps a torso view if possible, and the ability to move back and then be able for a musculoskeletal examination like shoulder rotation or turning a can or being able to bend over. For children, having a favorite toy to keep them calm. And then in the pre-visit planning, suggesting that the patient avoid bulky or tight-fitting clothing so you can see the respiratory rate so you can really examine what's happening with them. Ask them to obtain, prior to the visit, simple common exam tools like a flashlight, a scale, a thermometer, a blood pressure cuff so you can obtain observed vitals. And then in some cases, especially with children and sometimes with older adults, having a caregiver to assist in the examination is critical. I love this. This is from one of our partners in the area, and they provide this to all of their patients before a telehealth visit, helping them to understand what they need to do for a successful telehealth visit. They talk about the calm setting, sitting with your child in a well-lit room that's quiet and free from distractions. If they're nervous, helpful to have a toy. Using the smartphone, checking in 10 minutes in advance like we were supposed to do for the meeting today, so that you can confirm your scheduled appointment time and do a pre-call test. tools such as the thermometer, the flashlight, a scale. And then what are the expectations of what the visit's going to be like? And asking you, the parent in this case, to be part of the child's examination, and then using the phone to see the throat, push on their belly, move arms and legs and other tasks, and not being afraid to ask questions. Now, this is best done if you're creating your standard work for this as we rebalance our practices by creating standard work for our rooming staff, our CMAs, or the people who are going to be setting up our virtual visits. If this is done in advance, then the visits are far more efficient. When I surveyed providers, I found that some providers were taking 30 minutes or more to complete a virtual visit, which turned out to be a level 3 visit. And that's not effective use of your time. So how can we shorten that time and make it more effective? Well, that's by creating that rooming process. I encourage you to use lean processes to co-create the standard work with the people who do rooming so they know what details they need to get, including vitals in advance, the history of the present illness, going over the past medical history, the allergies, and doing the med reconciliations. What an opportunity we have at home when the patient's with all of their pill bottles to do an effective med reconciliation. Publishing this in advance so they know what their expectations are before they do the virtual visit. Pre-testing the connection, we talked about it. And then pre-planning for interpretation or a person to aid in the room is critical. So lights, camera, action. We're ready to go into the room, the virtual exam room with the patient. The first thing you want to do is maintain eye contact, and that's critical. And we'll talk about that in just a few minutes when we share the screen with you. And recognize them by their name so that they feel that you know them. Thank them for having the visit with you and tell them you're sorry that they're feeling bad. Observe the patient in their setting. Think about those 3 key criteria: home, acuity, and cognition. So what do their surroundings look like? How sick do they appear? Are they flushed? Do they appear diaphoretic? And cognition, are they speaking in sentences? Are they able to understand and follow instructions? Asking open-ended questions is critical in video visits because you want them to give you as much information as possible. And using what our nurses use really excellently is teach back, where you repeat what the patient said and then you extend it by saying something that can clarify it or expand it and get the detail more refined. In a virtual visit, we forget that patients are watching us with a camera. So if we look away from the camera for any reason, perhaps to review the chart, if we look down at our keyboards and start typing and they hear the clicking of the typing, they don't know what we're doing. So take them in the journey along with you virtually. I'm looking over to my left because I want to look in your chart and see if you've had something like this before. I'm looking at your meds to see what kind of medication I might prescribe for this. Let them know exactly what you're doing. If you're typing or writing something down, say, I'm documenting this so that we can have a clear record of what we did today so that we can know if this is effective or not. Use the camera to your best advantage. A picture is worth 1,000 words. Ask the patient to move the camera around to see what you need to see. Consider capturing a photo to document rashes, lesions, or swelling. Sometimes it may be, hey, take a picture of this and send it to me later through the patient portal. Or if you have the capability, depending upon the type of platform you're using, some platforms allow you actually to freeze a frame and take it as a picture. William Osler said there is no more difficult art than the art of observation. So we're going to take a second in just a few moments for us to start a virtual visit together. And so I am about to activate my camera on a live demonstration. So hello, how are you? I hope you're doing well today. Because of the COVID, I really haven't been able to do the self-hygiene I needed to do to get my beard trimmed and my hair cut, but hey, it's what it is. So you all experience something crazy. because I looked like maybe a bear. And your thought process as to what I looked like immediately informed what the quality of the visit was going to be, how we were going to interact. And that was exaggerated. But in reality, that's what it is in a virtual visit. If you're not looking at the camera and you're looking away, you can actually feel the rapport drop. If you're looking straight into the camera and communicating directly, in this case, I'm communicating to Tina, one of our hosts, and saying, hello, Tina, how are you? I hope you're doing better than I think you are. I understand you're kind of sick. So we're going to meet today and we're going to figure out exactly what's wrong with you and make a plan together. So that communication is critical. 3 parts to the setting before you get started. One is the camera. We've talked about looking into the camera to create the illusion of eye contact. We also talk about our positioning in the camera. The distance between the camera and me is about 2 feet to 3 feet. This allows me to be centered in the camera and not cut off. If the camera angle is too high and I look like I'm up here, I kind of look like I'm kind of crawling into the space. And that's kind of frustrating to the person. If the camera is too low, then they're wondering, hey, what is he really saying? So centering yourself into the camera, getting a good picture of you in the camera and being center stage is really critical. Eye contact is critical. Lighting is critical in this picture. The next thing is the way I appear. So I was never seen in my office without a stethoscope around my neck. So I'm going to wear a stethoscope in my virtual visit. I also always wore a sports coat, so I got a sports coat. So I look like Dr. Jenkins to the person that I'm having the visit with, and that's critical as well. The background, make sure that it's not terribly distracting. You can have a bookcase, you can have stuff in the background, it's fine, but just don't have a poster of The Walking Dead in the background, because that could be annoying to see a zombie. And make sure that there are not kids playing in the room or your wife or husband walking across the room or roommate walking across, because again, that is a HIPAA violation and it also communicates a lack of confidentiality for the visit. You also want to be careful about another setting. So if you look at me now, you see I'm centered and it's okay, we're communicating, but what do you see in the background? An open hallway, a door. And psychologists tell us that 2 things are happening in your mind right now. Number 1 is you're wondering, why is the door open? Who's going to come through the door? Who's listening to me on the other side of the door? And you're feeling uneasy about the confidentiality. Another weird thing that happens to people when they see an open door like that, they think Dr. Jenkins is going to get up and leave. So they really feel a pressure in the visit. So making sure there's not an open doorway in the background is also one of the pearls that we've learned from doing this. So in reviewing, camera, good eye contact, centering on the camera, about 2 feet so that they can see your hands because you're going to be gesturing and communicating with them, making sure that you're wearing appropriate garb that creates that rapport that you're their physician. So if you wear scrubs, wear scrubs. If you wear a white coat, wear a white coat. These are critical factors. A non-distracting background without any open doors or any people moving across the room to create that confidentiality. So now you're about ready to let the patient into the room because you're ready, you're on stage. If you've had a rooming process, things are going to be very efficient from now. If you haven't had a rooming process, you're going to have to obtain the history of the present illness and the vitals. So there are some tricks of the trade to obtaining the vitals. So the first thing is that I might ask the patient to help me get some of the vitals together. So I've asked them saying, hey, we said before we get started to have a thermometer. I want you to take your temperature and then show me the reading on a simple thermometer. I can get them to pull it up to the camera so I can see the reading and record it. If they have a blood pressure cuff, I'll get them to take their blood pressure and show me the reading on the blood pressure cuff. Makes it very efficient, and also observed vitals like this count as vitals in the chart for documentation purposes. The other part of it might be their pulse and respirations. In our offices, we estimate respiration, so I'm going to watch them. Again, that's part of that observation that I'm going to want to do. And then I might get them to show me, can you take your pulse? Do you feel your pulse? I can either do it from their carotid pulse or from their arm, whichever one they do. And then I'm going to ask them to call out their pulse for me. I'm going to watch my watch for 20 seconds, but I'm not telling them that. I'm just telling them call out their pulse. When I get to 20 seconds, I'm going to say stop. And I'm going to ask them, was it regular? Did it feel regular? Did it feel strong? So that I can comment on that. And I'm going to multiply it times 3, and I'm going to put it down as their pulse in the chart. And I've gotten now at least 5 vitals: respiratory rate, pulse, temperature, blood pressure. Weight's another possibility that I might be able to get from that by having them step on a scale and taking the camera and showing me the scale. Then we're ready to move into the history of the present illness, which you're all very good at, asking the questions, collecting the data, why they're having to visit today. We're going to say that Tina is having a visit for upper respiratory tract infection. She has sinus pressure, she's got postnasal drip, she's got a cough, and Mike Coughlin has really been bugging her and saying, Tina, I think you got the COVID. You better have a visit with Dr. Jenkins. And so she's arranged for a video visit to have a conversation about her upper respiratory tract infection. We've talked a lot about it. She didn't have a fever. She's pretty comfortable. We're ready to move into a co-physical examination. So what were the 4 things that we all learned in med school that were criteria for our physical examinations? Do you remember them? The first was observation, and then we did percussion, and then we did palpitation, and then we did auscultation. Well, auscultation is a little bit hard, although peripheral devices exist for us to do it. So if this becomes more commonplace, we might provide more and more of those sorts of things, like a digital stethoscope for some of our patients. But today we can do much of the other parts. So the first thing I'm going to do is I'm going to observe. So I'm looking, I'm seeing if Tina's in any distress. I'm looking at her face for flushing. I'm watching her respiratory rate. I'm seeing she may be disheveled or not disheveled because she's feeling really bad. And so I'm talking to her about that as we get started. And now I'm going to ask her to look in the camera for me and let me see her eyes, because her eyes look a little bit puffy for me. So I'm going to get her to get as close to the camera as possible. I'm going to look at her eyes. I'm going to get her, hey, Tina, will you look up? Will you look down? Will you look to the right? Will you look to the left? Will you look kind of diagonally for me? So I'm going to be looking at her eye movement. So I'm doing some cranial nerves at that time. I'm also watching and observing the puffiness around her eyes and seeing what that might be. So, hey, Tina, I think your right eye looks a little bit puffy. So I'm going to want you to examine it. Now, if you do ask the patient to examine a part that's near an entryway of infection, I always ask the patient to go wash their hands for 20 seconds and come back. It doesn't add much to the examination time, but it's a good procedure to do. So Tina, run, go wash your hands for 20 seconds, dry them, and come back and bring a towel, paper towel with you. So she comes back. Now I get her. I said, Tina, I think your right eye is swollen, this one. And so I want you to start by feeling the left eye, which I think looks pretty normal. So I get her to palpate for me along the eye and say, how does that feel? Get her to describe it. Is it smooth? Does it feel puffy? Is it tender? Now we're going to go to the puffy eye, and I'm going to get her to examine that. And I'm going to ask the same questions. Is it puffy? Do I feel granularity? Is it tender to touch? So that I can see if there's any swelling or puffiness in the eye. Next, Tina and I are going to go through percussion. I'm going to teach her percussion by getting her to tap on her wrist. So there we go. And feel that pressure, because that's the pressure I want you to use. And then we're going to start over the left sinus, then over the right sinus. And I'm going to ask her for difference in sensation. Was one side more tender than the other? Did it hurt when she palpated? I'm going to get her to do again below the eye and take her through palpating below the eye for sinus pressure and tension. And ask her, how does that feel? She can put her glasses back on because she's like me, she went blind. So then the next thing I'm going to do is go down to the oral pharynx. So I'm going to get her to get as close to the camera as possible and open her mouth wide. I'm looking back. And it may be that I can't get a good visualization. So I'm going to use the flashlight, get her to look in the back, or I'm going to ask her to turn the camera light on, the flashlight on the camera, so that I can see in the oral pharynx, so I can get a good picture. And I see she's got some kind of swollen back of her oral pharynx and redness, and there's some postnasal drainage going down the back. It's all pretty clear, you can see with most cameras now, with bringing the camera close to the mouth to see. Then I'm going to want to ask, does he have any tenderness in her neck? Because I want to feel for lymphadenopathy. So what I'd like to do now is teach her how to do an examination. So I'm going to ask her to use 2 fingers. And the first thing we're going to do is get our landmarks. And this is also part of a lot of examinations, whether it's the shoulder or the abdomen or the neck. You want to start with instructions on landmarks. So the sternocleidomastoid is a muscle that starts underneath your ear, Tina, and goes all the way down to the notch right in the middle. I'll back up a little bit so you can see me. Good? Okay, so right underneath the ear and there, and then there's a matching one on the other side that goes down. We're going to go behind that muscle, and we're going to go in front of that muscle, and we're going to use circular motions to kind of go down behind it. Do that for me? Perfect. Now go in front, use a circular muscle. Do you feel anything? You normally might feel some grainy things, or you might feel some things about the size of a pea, but is there anything larger or tender that you felt? And if Tina does feel something, get her to come do a close-up for us, and let's look there and get her to actually, if I can get my camera angle here, get her actually to pinch it with her fingers so that you can get an estimation of size. So you've done a rough adenopathy examination. You've gotten an estimation of size of the lymph node to know that if it's an important lymph node as a part of your diagnostic paradigm for your patient. Then I'm going to get her to breathe. So I'm going to get her to step back for just a little bit, and I'm going to watch her take a respiration in and out through the mouth. Do it one more time for me, Tina. In through the nose and out through the mouth. So what am I looking for? I'm looking for nasal flaring, accessory muscle use, paroxysmal movement while breathing. I'm listening for any wheezing, and I'm going to ask her if she hears any wheezing when she does this. And last but not least, I may get her to swallow so I can see if the trachea is midline, I can see if the thyroid is enlarged as part of examination. And I've pretty much completed an HENT examination. At the end of this slide set, I've incorporated a 2-page HENT exam with even some more hints for a more complete HENT examination, especially for specialists, that was provided by Stanford University. I've also, at this end of this set, provided an abdominal examination guide that was provided by Mayo Clinic. And you can find many of these guidelines on the web so that you can complete virtual examinations, but we've done an HENT examination because that was our chief complaint today. We also are going to do some podcasts in the future and use neurologists, gastroenterologists, other specialists to help really hone in on what we can do virtually and teach us to do more complete virtual examinations with our patient as our hands in the exam. So now we've made a conclusion, you've got your plan together, you've gotten all your history, you've listened to the patient, you've examined the patient together, you're ready to make your diagnosis. You think based upon its history that she was in the garden because it was kind of sunny this weekend, and she planted a bunch of plants and mowed her yard, and she did some other things, and you think, hey, this is bad sinus drainage from allergies, and she's had allergies in the past, so you're going to want to approach it that way. So you make your plan of nasal lavage with saline, some Zyrtec, maybe a nasal steroid spray, whatever is your protocol that you would do that. And you give her the expectations. And this is really critical. As you're making that good eye contact, you tell her this is what to expect. If this is an allergic symptom and we put you on these medications and you do the saline lavage for me, you should get better. It might periodically get worse when you get exposed to the things you're allergic to, but you should be able to control it with the medicines that we give you. Then you want to communicate what shouldn't happen. And what shouldn't happen is you shouldn't get a fever. You shouldn't feel short of breath. You shouldn't get chest pain. You shouldn't develop a productive cough. You shouldn't feel achy all over, because that would indicate that it's something other than your allergies being flared. And we would need to talk again. So what to expect, then go over what not to expect. If you're calling in a prescription because your copay for a nasal steroid is cheaper, confirm the pharmacy that you're sending it to. That's really important as part of virtual because you don't want to call back because that pharmacy that she normally uses is closed. So confirm the pharmacy. I always confirm allergies at this point too, just to make sure that I'm copacetic with that. And then I tell the patient how I'm going to communicate with them. If they have a patient portal, I'm going to send them to the patient portal the visit summary. If they don't have a patient portal, I'm going to ask to make sure that they gave us, or I have in their chart, their phone or their email, and either way I can communicate with them. And I'm going to either text it to them or I am going to email it to them, a copy of the after visit summary. It's really critical. The last thing that you want to do is to end the meeting. So what's the right way to end the meeting? Bye, see you later, click. You've cut off the meeting. So if Tina had some other questions or she really wasn't understanding it, she did not have the chance to reach out to you. And she's going to feel that, and it's going to affect her satisfaction. It's also going to affect the likelihood that she might call again. So summarize and then thank them for the visit. Hey, thank you for the opportunity, Tina, to be your doctor today. And if you have any further questions for me, I'm here for you. And if not, then I want you to go ahead and sign off and get that information I sent to you, read over it, make sure you understand it, and then go to the pharmacy or send your family to the pharmacy to pick up what I prescribed for you. Okay, Tina? And let Tina exit. Psychologists tell us that the fact that the patient exits the room first allows the patient to control the completion of the visit, and higher satisfaction and less likelihood that they're going to call back because they didn't get the service they think they needed. So we're at the end of the visit. We've completed the visit. We're ready to log off, and then create that quick note. If during the visit I needed to record, what should I do? I should tell Tina, hey, Tina, I'm typing some things down. If I needed to look at her chart to confirm her allergies, Tina, I'm looking over to the side and I'm looking at your chart so I can confirm your allergies. Again, applying some of the principles we talked about earlier to take the person on the journey with us virtually with eye contact and clear understanding of what's happening. And this is how you can complete a visit with high satisfaction for conditions that are appropriate. We know that the CDC.gov talks about sinusitis as primarily diagnosed from history. And so for virtual visits, it's a great condition. Virtual visits are probably not, and you've experienced that in the COVID crisis for some conditions. And so again, it's not going to be everything we do, but if we do proper pre-visit planning for these virtual visits and acute issues, then it can be a great tool in our armamentarium for us to provide patient-centered, efficient, effective care. So let's see if we have any questions. Tina, or do we have any questions that people would like answered today?
Any in the chat box right now? Let's give them just a moment. If you have a question, please put it in the chat box.
Good deal. So as we move forward together and apply these principles, I think you're going to find it'll be easier and easier and easier to do that once you've got it set up and you get comfortable about what eye level is and where your screen is and what you're using. I use two screens just because it's easier for me to have this other screen open with the chart on it. So if I need to look at it, some people use one screen. Another little trick is to help with eye contact. I have Tina's picture right underneath my camera. So if I'm glancing at Tina to see how she's doing, to see if she's understanding, it still gives the illusion that I've got good eye contact with her in my conversation. So I see a question pop up. Is that the one?
I believe from Mark.
Yep, Mark Holstrom.
Yes.
So what are some best practices for pre-visit planning? So when I look at systems across the country who are doing this right now, and interestingly, there's a group called Group Practice Improvement, which just had a series of webinars with about 20 or 30 different systems talking about what are these best practices. And in that group were Kaiser and Intermountain and several of the others. So what are some of the best practices? One is to make sure that the CME reaches into the patient room before you do. So many of our systems that we use allows your CMA to enter into the patient's room prior to the physician entering into the patient's room and actually doing a rooming job. So the most efficient time for you is if that CMA is collecting the vitals, collecting a summary of the history of the present illness so you know what it is before you walk in, you see it in the documentation, going over the past medical history, the allergies, and doing the med reconciliation before you get there. That really helps you from the documentation side. Best practices from the experience side is they're confirming the link, they're talking about the light, they're talking about privacy, they're making sure that they have the tools present for you to be able to effectively do the examination. And they've created the expectation of how Dr. Jenkins is going to talk with you and what he's going to ask you to do. And if they are wearing a coat and a sweater and gloves and a hat, they may ask them, hey, take off some of the layers so that he can see how you breathe and do things like that. So that's really critical work around that. Each practice may need to create their own standard work depending upon if they have a CMA or an MA or who can do the rooming work. But if you have that standard work in place, it's going to shorten your visit considerably. Key issues that take the longest are med reconciliation and review of those past medical things that we have to click off to get credit for our visits. And as we move into the norm, documentation requirements may loosen somewhat for virtual visits, but we're still going to have those parts of the visits that we need to go through. There was another question, Tina.
Yes, Cheryl wanted to know, should we move toward doing virtual visits in the office or at home?
So that's a great question. So here's one way of looking at it, the way I look at it. If you had 4 providers in your office and you had 12 exam rooms, if you were to schedule one of your providers to spend 2 half days a week at home doing virtual visits, then you would open up enough space in your clinic to add a 5th provider. So from a standpoint of efficiency of outpatient care, my predilection is to have the virtual provider remain at home. And I think that is what most systems are moving towards for efficiency and effectiveness. A virtual provider doesn't need a check-in, a check-out, a lab tech, all the things we have in our office that create expense. A virtual provider may need a roomer, and that roomer could work from home. So that some of your CMAs and MAs might find it very satisfying to be able to work from home as your virtual roomer. And because everything is digital, then it can be accomplished from home. Tina, there was another question.
Yes, Dr. Floyd would like to know, are there special steps if the doctor and patient are in different states, particularly for non-Medicare?
Yeah, so right now, most authorities believe that the waiver covers you if your patient's in a different state, because most of our insurers have said that they will default to Medicare's guidelines. It is going to take a legislative action after the waivers are removed for us to be able to have interstate. Certain states have relationship with other states, and there are states that allow that. We don't have that locally. So when I did virtual visits prior to COVID, I had to make sure that the patient was in North Carolina when I had a virtual visit, because I don't have a licensure in Virginia. But if they were in South Carolina, because I have a licensure in South Carolina, I could have a visit with them. We're hopeful that 2 things are going to come before the waiver disappears. One would be this idea of that providers who have an established relationship with a patient can have that visit with them virtually no matter where they are in the territorial United States. And secondly, that we will have some clarification about originating sites and distant sites, so that we would know that we can provide that care for the patient in their home, and we can know that we don't have to be in the office setting. And that is going to take legislative action after the COVID state of emergency. Yes, somebody asked if there's a national medical license. There's not a movement towards a national medical license, because your board has a responsibility to protect the people of its state from any malpractice or any bad actors. So the medical board has a state responsibility. The idea, though, of having a medical license like they have in nurses that is recognized, so the states have an agreement. So if North Carolina certifies me, the states within the agreement will recognize that licensure. And still, though, my home state would be responsible for disciplinary action and all that sort of stuff.
When is the waiver set to expire?
Okay, currently the waiver is going to go through July, and that's been announced by Medicare and by Medicaid in our state. And it all depends upon how we open up and what that looks like. There are meetings going on right now at DHHS talking about how COVID has influenced access to care. We're looking at well visits falling to the wayside. We're looking at immunizations falling to the wayside. And there is a general thought that for health equity, for access to care, and because of the fact that patients have become used to this, that we will continue some parts of the waiver after July. The factors that we talked about that have to be legislative have to be the idea of the distant site and the originating site, as well as other aspects of state licensure.
Kathy would like to know, do you think there would be significant improvement in access to care if nurses taught patients how to access telehealth services or facilitated visits with equipment that integrates with the practice telehealth system?
Sure. So that's kind of a wonderful future state. So I think that in some point we will, especially people with chronic medical conditions like congestive heart failure, they already do this in CHMG cardiology. The patient is taught how to take their weights, how to take their blood pressure by a nurse, who then that's collected in the virtual visits. And so, yes, that is a great future state to do. Jules, I saw, was on the call, and Jules will tell you that that can be standard work. That's reproducible. So that could be a CMA who is following reproducible work. An RN would need to be the team lead of those teams, but you could do that with CME staff as long as you've created reproducible standard work.
Tracy has a question. If it is determined that patient needs lab work, any recommendations on how that can or should be done?
Good deal. So there's a couple of best practices out there during the COVID, and I love that. There's one group that's out in the eastern part of our state, Roanoke, Chowan, and since they're documenting the virtual visit within their EHR record, the provider then puts an order in for the labs, and they have a drive-up lab, so the patients feel safe about it. That could be to a certain time for an appointment, that you could turn it back over to your CMA, who could say, hey, we have a safe time for you to go to our lab for your blood work, and no COVID people are going to be in the lobby. We're going to make an appointment. You're going to sit in your car. You get called into the lab. So there are lots of ways operationally that people are creating that rapport, that empathy for what the patient's feeling, and making them feel safe to come back to our offices for the needed labs. But generally, we recommend, if you're documenting into the chart, put the order in at real time if they need blood work doing at that time for their visit. Or immunizations, especially if you're doing a wellness visit, both with a senior or a child, they've got immunizations that are required. So you can put in that order for that MMR. You can put in that order for that pneumonia shot, and then they can go at an appointed safe time to the visit.
We have just a few more minutes. If there's any more questions, please put them in the chat box. Thank you.
You guys are good. These are great questions, and they're faced by everybody across the state as they operationalize this hybrid between in-person visits and virtual visits. And we move towards, hopefully, an environment where we have a policies and procedures that we put in place where our patients feel safe to come back to our office, and we have efficiencies in place so that we can get the flow through our offices. But like I said, most experts are telling us that for the time being, we're going to still need to see about 25% of your patients virtually, simply because of how patients react, their choices, and also what it takes to be able to flip an office safely for the patient.
There's a question from Stephanie. Would be handy for CMA to glance at the illustrated instructions. Will we have access to that?
So I'm actually talking with AEC about that. So you'll have access to my slides, and we're talking about maybe doing a CMA rooming tip sheet for virtual visits or a nurse rooming tip sheet and get that out from our practice managers. So I'm going to recruit them because there seems to be an interest for that, and we'll try to get that out to you very soon on our AEC site. We have a lot of tips on our AEC site, by the way, if you're not aware of it. We have billing tips, we have coding tips, we have some practice tips, especially in behavioral medicine and other types. So all of these resources are available through your practice resource team, both in our website and if you contact the practice support people.
I don't believe we have any questions right now.
Good deal. Well, thank you guys for participating, for being such an active audience. Hopefully we will continue to have opportunities to learn together. Again, have a great day.